Hello everyone, greetings from IJA. This is Dr. Karthik AR. Today I'm going to present an original article from the November issue of the Indian Journal of Anaesthesia. So the title of the article is Comparison of Target Concentration of Propofol during 3 phases of live donor liver transplant surgery using a target controlled infusion of propofol total intravenous anesthesia, a prospective observational pilot study. This study was conducted at the Institute of Liver and Biliary Sciences, New Delhi, India. Introduction. Propofol has been successfully used in liver transplants for induction and maintenance of anesthesia. Liver transplantation consists of 3 phases, namely dissection, anhepatic, and neohepatic phases, which present 3 different pharmacokinetic situations for propofol. In the dissection phase, acute hemorrhage and cross-clamping of the IVC and portal vein reduces propofol requirements, and resuscitation with blood and fluids increases propofol requirements. In the anhepatic phase, a reduction in propofol clearance is seen due to the absence of liver. In the neohepatic phase, restored hepatic function increases propofol clearance, thereby increasing requirements. Pre-existing cirrhosis further complicates propofol pharmacokinetics, especially in those with higher CTP scores, Child-Pugh scores. So the research question and objectives were, due to lack of studies on propofol dosing during live donor liver transplantation, they hypothesized that the concentration of the propofol would be different in different phases in the transplant. Primary objective of the study was to compare the mean target concentration of propofol (TPC) required to maintain a BIS between 40 to 60 during 3 phases of live donor liver transplantation using a target controlled infusion of total intravenous anesthesia. The secondary objective was to study the effect of increasing MELD scores on the propofol dose requirement during liver transplantation. Ethical approval of the study was received from the Institutional Ethics Committee in 2022. Study was registered with the Clinical Trials Registry of India. The study was designed as a prospective observational study in 20 participants. The inclusion criteria were age 18 to 65 years undergoing elective live donor liver transplantation. The exclusion criteria were patients denying consent, allergy to egg or propofol, known psychiatric or neurologic disease, chronic kidney disease, previous spontaneous bacterial peritonitis, portal thrombosis, deviation from the protocol of anesthesia, and hepatic encephalopathy. Methodology. AAC standard monitors were applied. Initial BIS value was noted. Induction was done with boluses of fentanyl, propofol, and atracurium, and tracheal intubation was done. When the BIS value was more than 60, propofol TCI MARSH model was started with a target propofol concentration in the plasma of 2.5 microgram per ml. The TPC was decreased or increased by 0.2 microgram per ml whenever the BIS values were persistently lesser than 40 or more than 60 every 15 minutes. Intravenous infusion of fentanyl at 2 microgram per kg per hour and atracurium at 0.5 milligram per kg per hour was given throughout the surgery. Fluids were administered at 10 ml per kg per hour during surgery, and a bolus of 250 to 500 ml was given if the mean arterial pressure fell below 55 millimeters mercury. Vasopressors like norepinephrine and vasopressin were initiated when hypotension persisted despite adequate fluid and blood replacement. All patients were shifted to the ICU for elective ventilation and extubated the following day. Demographic data such as the age, weight, and BMI, MELD scores, CTP scores, and decompensations like ascites, hepatic hydrothorax, esophageal varices, hepatorenal syndrome, hepatopulmonary syndrome were noted preoperatively a day before surgery. TCI concentration of propofol, BIS values, vasopressor dose, hemodynamic parameters like mean arterial pressure, heart rate, stroke volume variation, and cardiac output using flow track, and temperature using an esophageal probe were recorded every 15 minutes intraoperatively. The total propofol consumed in each phase was recorded at the end of each phase from the reading of the TCI pump. All patients were interviewed about intraoperative recall on the second or third day after extubation using the modified Bryce interview. Primary and secondary outcomes, as mentioned earlier, were noted. SPSS software version 25 was used for statistical analysis. The categorical variables, namely etiology of liver disease, gender, CTP scores, and MELD scores, were presented as numbers and percentages. The continuous variables, namely age, weight, graft versus weight ratio, GRWR, duration of each phase, mean arterial pressure, heart rate, cardiac output, temperature, BIS values, noradrenaline vasopressin requirements, TPC of propofol, and propofol requirement in each phase were presented as mean and standard deviation values. The quantitative variables TPC and propofol requirement were compared using ANOVA, and repeated measure ANOVA was used to compare dissection anhepatic and neohepatic phases, followed by a post hoc Bonferroni correction test. For statistical significance, a p-value of less than 0.05 was considered statistically significant. So the results were presented as the demographic parameters in this table, showing the age, gender, weight, etiology of chronic liver disease, MELD scores, CTP scores, and GRWR values. The intraoperative parameters were shown in this results table, which included the duration of phase, mean arterial pressure, heart rate, cardiac output, temperature, BIS values, noradrenaline requirement, vasopressin requirement, mean target plasma concentration of propofol, and dose requirement of propofol. The mean target plasma concentration, which is the primary objective, was compared between the dissection and the anhepatic phase and was found to be statistically significant with a p-value of less than 0.05. The mean TPC between the dissection and the neohepatic phase was also statistically significant with a p-value of less than 0.05. Between the anhepatic phase and the neohepatic phase, the p-value was more than 0.05 and was not statistically significant for TPC. The secondary objective, there was no difference in mean propofol consumption with increasing MELD scores. The propofol dosage was 119, 134, and 173 for MELD scores between 15 to 20, 21 to 25, and more than 25 respectively, with no statistical significance, p-value more than 0.05. None of the patients had any history of recall after surgery. Discussion. In the study, the mean TPC of propofol in all the phases of live donor liver transplantation was notably lower compared to the maintenance dose of 2.5 to 4 microgram per ml typically administered with opioids in standard surgical patients. Furthermore, this discrepancy highlights a reduced TPC in both the anhepatic and neohepatic phases relative to the dissection phase. In cirrhotic patients, a lower hepatic blood flow, hypoalbuminemia with higher free propofol, collateral circulation diverting portal flow to systemic circulation, all these contribute to propofol requirement to be lower in the dissection phase itself. Propofol requirement was reduced to 61% in the anhepatic phase and 63.7% in the neohepatic phase compared to the dissection phase. The lower dosage in the anhepatic phase is expected due to the absence of liver function and reduced cardiac output resulting from portal and IVC clamping, which diminishes hepatic blood flow and peripheral distribution of propofol. The increased propofol requirement observed in the neohepatic phase compared to the anhepatic phase can be attributed to the clearance of propofol by the newly implanted allograft. The authors have explained the choice of Marsh model over the Schneider model was done because of the lower propensity for plasma propofol overshoot, up to 150% of the target concentration in the Marsh model compared to the Schneider model, which is more than up to about 300%. So this reduced overshoot in the Marsh model minimizes the risk of hemodynamic instability, which is crucial during liver transplantation, which is a procedure characterized by significant fluid shifts and blood loss. The limitations given by the authors are a small sample size, lack of plasma propofol concentration measurements, lack of closed-loop anesthesia delivery systems, which could have provided precise titration of propofol dosage. Blood loss and fluid administered was not measured separately in each phase. So to conclude, The mean target propofol concentration when using a TCI pump should be adjusted to 61% and 63.7% of the dissection phase levels during the anhepatic and neohepatic phases, respectively, to avoid overdosage and ensure optimal anesthesia management. The authors have disclosed no conflicts of interest and no financial support for the study. Thank you.